Thank you very much. One of the task groups at AAPM is considering in terms of SPECT-CT and sort of end with some clinical applications that we are seeing in the clinic right now. So SPECT actually stands for Single Photon Emission Computed Tomography, so it is basically an acronym here. So just to kind of get everybody on the same page, when we do nuclear medicine imaging, is we administer radiopharmaceutical to patients. So we normally do it by IV, it can be an oral, or it can be actually inhaled as well, but most commonly we do it intravenously. And then we wait for a certain amount of time for this radiopharmaceutical to get an optimal biodistribution within the body. So for example, if you do FDG scan, 60 to 90 minutes is a time we have to wait for there to be an optimal equilibrium sort of in the body. If you do an MDP bone scan, we're talking about 120 minutes to 180 minutes. So sort of it depends a little bit on the clinical practice. So obviously, as soon as you have administered the drug, there is decay going on, okay? And so while the biodistribution is occurring, the patient is radioactive, okay? And then once the optimal time point has been achieved, we basically put the patient in a scanner, and if it is SPECT, we put them under a gamma camera system, and if it's a PET radionuclide, we put under a PET system here. And the idea is we detect the emissions coming from the patient, and we generate tomographic images. So the point of PET and SPECT is actually looking at, we want to visualize the functional information based on the specific radiopharmaceutical, okay? So we're not necessarily looking at anatomy per se, but looking at actually what is the functional information that is happening within the patient. So when we talk about a SPECT or a SPECT-CT system, at the heart of a SPECT system is something called a gamma camera, okay? And so a gamma camera, I have shown a cartoon here on the left here, and basically most gamma cameras right now are made out of a sodium iodide scintillator, and this has been a scintillator of choice for many decades, and there's a reason for that. You can actually generate large crystals economically. They have, actually sodium iodide is one of the highest light output scintillators there is. It's got a pretty good energy resolution, and it's got good stopping power for 140 keV photon, which is really the bread and butter radionuclide used in single photon imaging. We use indium-111 and I-131 and I-123 as well, but really, Tech-99M is really the bread and butter imaging radionuclide. So what a gamma camera looks like, you have a big, large array, monolithic sodium iodide crystal, and the back end, there is an array of photomultiplier tubes. And these photomultiplier tubes looks at the distribution of light that is coming after the photon interacts with the crystal. And there's some electronics in the back you can see out here. And then basically it determines the energy and the location of the photon. And before the crystal, there is also a collimator, so we can get some sense of the positional information. And in nuclear medicine, we do photon counting. So this is very different than, say, CT or mammography lectures we saw today. So we're actually measuring individual photon. So we have to follow Poisson statistics. So we kind of see that this energy resolution and the spatial resolution depends on the sort of the number of photons that are detected. And if you sort of follow Poisson statistics, you see that the spatial resolution, energy resolution improves at the higher the energy, the higher you are in the photon energy. Okay, so I talked a little bit about the collimator that actually sits in front of the gamma camera. So the collimator is not a focusing lens, like the one we have in our camera. It's an absorptive collimator. So the way a collimator works is traditionally made out of lead. It's a hexagonal shaped collimator. It's got the highest packing efficiency in terms of use of lead. So the honeycomb structure is most commonly used. And there's three basic parameters of a collimator. It's got the septal length, the hole diameter, and the septal thickness. And so there are different types of collimators depending on what sort of energy of photon you would like to image. And the idea is that you have a source of photon here. Anything that is basically diverging is going to be absorbed by the collimator here and stopped, while those that come normal to the detector is detected. So you basically get sort of a PSF, point spread function here. And depending on the characteristics of the collimator, the PSF changes, And clearly, to stop this photon here, you might need thicker amount of what we call septa, depending on the energy of the photon. So the resolution of a collimator is a non-stationary. It basically varies as a function of distance away from the surface of the collimator, okay? So, and that is what is shown out here. So the collimator resolution here varies as a function of distance, and it has, okay, distance right here, h, but it has some other dimensions associated with the properties of the collimator as well. So we basically have, when you look at distance and the net resolution, what you see is that you start off with some intrinsic resolution, and then that intrinsic resolution degrades the further away you move away from the surface of the collimator. Okay? And so the net resolution that you realize in a system is really the combination of the intrinsic resolution and the extrinsic resolution in quadrature. So one of the key points to note out is that resolution is highest closest to the collimator surface. So whenever you do nuclear medicine imaging, you bring this collimator head as close to the patient as possible. Okay? So we got, so it's a good thing to have a collimator because we can actually, get good resolution, but there's a price you pay, right? There's no free lunch. So what happens is there's efficiency issues out here. So the lead is going to be blocking photons that are potentially useful to, get an image. So we compute something called the efficiency to figure out sort of what is the price we are paying, in terms of putting this absorptive collimator in front of the collimator. So there is a component that is basically a geometrical component that basically says what is your solid angle that each of the collimator is looking at, and then it also has a fraction that what fraction of the collimator is actually covered by the lead. And I'm not going to go through it, but the take-home message is as follows. When you buy a gamma camera, you can get the specifications of the collimator, and you can compute those equations depending on the shape of the hole, what is the efficiency, and you can actually look at the parameters that you get for the collimator and compute the efficiencies. So the efficiency we're really talking about of a collimator is 1 part in 10,000. Okay, so that's a good number to remember. So that means for every 10,000 photons that is emitted by the patient in the direction of your collimator, one of them actually gets through. Okay, so although collimator is very important for us to actually generate an image, it actually has got a very, very poor efficiency. This is what we call the quantum sink, when you look at the imaging chain. The other thing to consider is sensitivity. So the idea is, okay, so does it matter sort of where you are with respect to the collimator in terms of how many photons you detect? And here what you notice is that we know that photon flux changes with inverse square, but the area that is detected by that same solid angle increases equivalently with inverse square as well. So basically the inverse square fractions cancel out, and the overall sensitivity of your system doesn't change dramatically. Okay? So that's a good thing. So it's not like you're going to suddenly see more photons if you're close by here. So really when you put your gamma camera close to the patient, it's not to see more photons, it's just to see more photons, the same amount of photons more clearly. And then Hal Anger in the late 60s developed a methodology to actually figure out how do you determine the position of a photon in a gamma camera by looking at the relative signal. Okay? And basically you can visualize this by if you have some signal coming out here, you read the signal out in the two ends, okay, and there's a very well-known resistive chain that is put across the signal. So by looking at the relative signal between one side and the other, you can determine along this axis where the position occurred. So for example, if the event was in the middle, there's equal signal. So when you do this math here, one minus the other, the y-axis, for example, is 0. If you go towards one side or the other, you'll see that one signal is attenuated less than the other. So looking at the relative difference between the signal, you can determine the position. Modern computers modern gamma cameras use more sophisticated algorithms to determine position. But this sort of is the, the kind of conceptual concept of, positioning. And then obviously the total signal that you measure is proportional to energy. And that is one of the hallmarks of a scintillator, right? The light output is proportional to the incident energy. So how do we do a SPECT acquisition? We have a patient here that is shown in this cartoon. Obviously, the photons are coming in all sorts of random directions. And then you have a collimator here that preferentially selects photons coming in this direction. There's a gamma camera here, so you get a projection image. And this gamma camera is then moved across the patient, so we see projections from different view. Okay, and that is what is shown here to generate a sinogram. So here's sort of a patient cartoon. You can see photons coming from different views here, and as the gamma camera moves around here, you are filling sinogram space. Okay, so here's an example of a projection image. You can see this is the gamma camera going around. You can see here the projections, and as if you draw lines along different anatomy out here, you can see you're creating different sinograms, and you can do FBP reconstruction, along each of these slices and create a volumetric data set. So that is, in essence, very simple way of actually generating SPECT images. So I told you, we don't just normally go in a circle. We try to come as close to the patient as possible to sort of increase the resolution. The other thing to note is that we have something called attenuation, right? So we have an object deep in the anatomy. If you have opposing views, you may not see the same signal. So for example, if you have a source of emission here, this view, the attenuation is impacted by this path length, whereas in the opposite view, the path length may be much shorter. So in this case, for example, when you have a posterior lesion here, it's visualized well in the posterior image, but the anterior image, it's not well visualized. So when we do SPECT imaging, we like to go a full 360 because it is not, the assumption that, opposite views are going to be exactly the same may not be true. So there's full 360 degrees that is acquired, except in the case of cardiac, where because the myocardium has so much anterior, there's very little signal that you see from the posterior. You actually only acquire 180-degree views. So when you acquire the SPECT data, there's some corrections you've got to apply in there as well. So we apply the intrinsic corrections, we apply the extrinsic corrections. Now I said we have most SPECT systems are dual head. There are some triple head systems out there. So we have to actually co-register the multiple heads as it goes around. So that's the multi-head registration, center of rotation corrections we apply. Some systems apply this interframe decay because it actually takes a finite time to actually acquire all the data. And then that is basically fed into your reconstruction toolkit. Okay? If you want to incorporate scatter or attenuation or some other response modeling, those then are also put into your reconstruction toolkit. And then traditionally you put the SPECT signal comes out in counts per ml, so it's not giving us activity concentration, it's giving us an analog, so counts of that. But some modern systems can incorporate scanner calibration as well, and now you can actually get SPECT in becquerels per ml, okay? So quantitative information. I talked a little bit about scatter correction. The most common way we do scatter correction in SPECT is to do energy windows-based correction. So the idea is here's a spectrum of indium that I'm showing you from a patient. And indium has 2 photon emissions, 172 and a 247 keV. But you see there's a lot of scatter within the patient. So this idea of Ron Jacek actually developed this energy window-based correction was that you put energy windows near the photo peak, and by determining what is the signal in the scatter window, you can estimate what is the scatter in the photo peak window. I talked a little bit about FBP reconstruction, but there is a lot of the physics in terms of the process of attenuation that we cannot really model very well with FBP. So there is this concept of iterative reconstruction, and the key essence of an iterative reconstruction is this probability density matrix. So the idea is that you want to know that if you have a certain voxel, what is the probability that for a given projection, what is the probability that it will create a signal in a given pixel in a certain projection? So you can incorporate in this probability density matrix all depth-dependent resolution parameters, scatter, and even maybe collimator response properties, okay? And then this probability density matrix is actually used in an iterative loop. So what happens is that you make a guess of what the projections look like, you go through and you forward project this data, and you look at your projections, then you compare your projections to what you actually measure. Based on this comparison, you create an error estimate, which is then fed into the previous estimate of your object, and then you iterate back. So this is back projected, and then error is computed, and then forward project again. So there's a forward projection component here, a back projection component here. And you iterate this for a while. So in clinical practice, we don't necessarily iterate till you hit convergence. You kind of iterate for a while for time constraints and practical considerations, and then you generate some images. So here's an example of how this process takes place for a series of point sources. So I've got a series of point sources here. So when I do the first iteration, that's what the image looks like, because it first assumes it's a uniform blob of activity. And then as you can see, as you iterate, and you basically go to 4 iterations on it, you can already start visualizing that you already achieved what I would call convergence, right? You see the sources. And then once you, let's say, for example, from 16, you go all the way to 64, you're not gaining anything else, right? You already achieved convergence. So one thing to note is that the noise properties of FBP versus iterative reconstruction is very different. And that is shown here where a window width and level the image quite low to be able to see the noise properties. So you can see FBP, the noise is quite uniform and, more Poissonian kind of everywhere. But once you do iterative reconstruction, you see the noise does not have this very Poissonian effect. Okay? It's very non-stationary. So there's a non-linearity in the noise when you do iterative reconstruction. And then here's an example of when I said, you have to do full 360 versus 180 degrees. So here's the same point sources reconstructed with 360 degrees. So you can see that all these points actually look relatively circular, obviously with the finite space resolution. But if you acquire it only for 180 degrees, you see there are these segments that don't have good adequate sampling, and you have sort of artifacts. Okay, so so that is one of the things you got to know. But physicians, when they're trained, to read MPI images, they understand how to interpret cardiac images. So we talked a little bit about scatter. We talked about iterative reconstruction. The other aspect is to do attenuation correction. Okay, so this was the main motivation actually to do SPECT CT is to be able to correct for attenuation that is stemming from the patient. So the idea here is to use X-ray CT. It's very fast. It gives you very high resolution anatomical images, and it does give you a slightly higher radiation dose, because in the past we used to use SPECT-based attenuation correction. For the interest of time, I'm not showing those slides, but in the past we actually used radionuclides to go around the patient and use those energies to create sort of CT images, not X-ray CT images, but radionuclide CT images. So that there's a couple of advantages by using X-ray transmission images is that you can actually overlay now this high-resolution anatomical images on top of functional images, and this has shown to be a very high value for clinical interpretation of nuclear medicine scans. So how do we use CT for attenuation correction? So it goes back to the equation of what the Hounsfield units are, right? So if we start with this paradigm, the Hounsfield units is basically mu of the material minus mu of water divided mu of water times 1,000, but that is all done at the CT energies. This is the effective energy of CT, say about 75 or so keV. But what you're really interested in is actually, let's say I do a SPECT CT of a bone scan, what is that attenuation at 140 keV, right? So I want to translate that. So we can rewrite this in the definition of Hounsfield units in this fashion where we get what is the mu of that material at the energy of the CT, and then I can transform it from an energy of the CT to the energy of the radionuclide that I'm interested in is by applying some scale factors based on the linear attenuation coefficient curves. Okay? So this has been done a long time ago. So this is the Bruce Hasagawa's group a long time ago actually developed this methodology. And what you notice is that there's basically two basic processes going on in the patient, right? There's this photoelectric interaction and Compton scattering. And we are all soft tissue, low Z material, so it's primarily photoelectric, but once you have a high Z material, you have photoelectric effect. So this factor, what we've noticed is that it basically has a bilinear term. Okay? So at low Zs, okay, low CT numbers, everything, it's all linear up to let's say soft tissue like 0 to 50 or so. But once you go beyond that, when you have bone and like calcium or contrast because you have high Z, because photoelectric kicks in, that slope of that curve changes, and that's basically reflected here. You can see air and muscle here. All these energies, they have very similar attenuation properties, and so does bone. It's only when you go to low energies, right, the photoelectric sort of kicks in because the Compton, it's very insensitive, right, to what material you have. It's all electron density based. So this separation at low energies, you have this bilinear term. So that's what is used. So we basically get the CT scan, okay? We make the CT scan to be the same resolution of the SPECT, or it's true actually in PET as well. We make the PET resolution, convert that using this bilinear transform into a mu map, and this mu map is fed back into that iterative reconstruction toolbox to actually when we do the iteration here, and we get the reconstructed SPECT image. So we could ask, so what quality of CT do I need if I want to do SPECT CT? So there's two roles that CT plays when you actually acquire SPECT CT. One is to do the attenuation correction, And this, by and far, is the most important function of the CT component of a hybrid SPECT CT system, right? Is really to provide good attenuation correction so you have high quality SPECT images. So you can actually get SPECT systems that have CT, attenuation correction CT only. So those have fairly low quality CT, but you get good attenuation correction properties from them. So one is to attenuate correct. The other is to localize the anatomy. And when I show you the clinical examples, you will see the value of actually having CT with the SPECT to kind of make the diagnosis. So the radiation dose requirements for the CT for these two metrics are quite different. Okay, so when you want to attenuation correction, you can actually go very, very low dose, and it doesn't matter. Okay, so if you want to actually get a good attenuation correction, you can do the lowest MA, the lowest KV, the images look really bad, but the SPECT attenuation correction will be perfect. Okay, so somebody says, what is the technique I need to do attenuation correction? The lowest MA, the lowest KV, you press it, and you're going to get good attenuation correction. Okay? So this is not the limiting factor. The limiting factor is really here, is that what quality of images does a physician want to look at, right, when he's looking at fused images for interpretation. So this is okay. So it's important to know that this is what drives the quality of the CT. Traditionally, as a good rule of thumb, what we find is half the dose that we do for a diagnostic CT scan seems to be reasonable, okay, at least in our practice, when we do SPECT CT scans. Okay? So a 10 millisievert scan seems pretty reasonable. Okay, so I kind of wanted to give you sort of an overview of what are the components of the SPECT, sort of the CT, reconstruction. Now I want to talk a little about the SPECT CT quality control aspect of it here, switching gears. So we have reports that talk quite a bit about how to do planar, QC, and here are the references for that. There is also reports like Report 52 that talks about how to use SPECT. So there's been a new initiative, well, it's not quite new, but a recent initiative in the APM to look at SPECT CT quality control. And so that's the Task 177 by Jim Hallermeyer, the chair of that. And so the SPECT CT component of that, basically we have actually one new test that we've incorporated, and that is really the SPECT CT image registration. So it's going to be a new test that the AAPM is going to recommend the community follow when we do annual acceptance testing of SPECT systems. Okay? We also have an image quality, but that really is very similar to the SPECT image quality, except we're using CT for attenuation scatter correction. So what is the image registration? So the idea here is that we want to verify that the registration of the SPECT and the CT are accurate, right? So when you do the fused images, you can associate anatomy with function with some level of accuracy. So this does not address image registration due to patient motion, okay? So you got to remember that SPECT CT are not simultaneous imaging, right? They are sequential scans. So you do either the SPECT first, and then you do the CT, or vice versa. So there is obviously a chance of motion between these two, and this test is not going to address that. So the idea here is we take a mixture of tech and some sort of IV contrast to visualize the data and to mix them up and create small point sources, okay? And that's what I want to show you out here. And then you basically fill some capillary tubes with this radioactivity, the very small tip. So very similar to this concept of if people have done like PET NEMA, right? This is how we would do a registration for a resolution, for a PET NEMA. We take these capillary tubes, we make a 1 by 1 by 1 millimeter volume of tech and now contrast, and we basically image them in the scanner, image in the scanner, and reconstruct the data. Okay, so we acquire SPECT and PET in air, and we're going to get the CT image, and the whole idea of contrast is we'll visualize those 3 points. And if you do SPECT reconstruction, and here FBP recon is fine because you don't really have any scatter attenuation. Okay, here you can just apply a simple RAM filter here, and then you overlay them up. So and then you look. Well, sorry. And I'll talk. So that's one approach. The other approach we're actually talking about, and I'll say how you do the analysis here, is that if you look at cobalt, right? Cobalt actually has an emission like about 128 or 130. It's a low yield photon, but traditionally due to the poor energy resolution of a gamma camera, you don't really visualize this peak. But if you overlay the cobalt peak with a tech peak, you see there's a substantial amount of cobalt signal that falls into the tech signal. So the idea here is rather than do like all these point sources, when we do our JZAC SPECT scan, why can't we just take some cobalt button sources, attach them, somewhere close to the SPECT system, and then acquire image in tech window, right? So it's one acquisition, and then you reconstruct these cobalt buttons, assuming they're tech, okay? And it works, okay? So that's what this is. So this is actually cobalt buttons that just image using a tech window. And by looking at, if you look at this image, there's a small air cavity within these sources. So you can, when you look at them in CT, you can identify the center of these very easily on CT, and you overlay the hot spot of the SPECT emission over there, and that's how you try to assess, basically, registration. Okay, so there's a couple of approaches. So how do you do that? So we have 3-point sources. This is what you're recommending. And we look at the X, Y, and Z shift of each of these point sources, and then you come up with some mean deviation of shift, right? The registration accuracy. And the pass criteria, we would say, is sort of, there's no exhaustive science as it has to be within this. But kind of from a first principles, you can say the mean deviation along any axis has to be less than 1 SPECT pixel, right? So at least everything is within a SPECT pixel. So that seems like a reasonable approach. So that's what the task force is going to recommend. The other area is we want to encourage people to do a SPECT CT of an image quality. So in this case, the idea is you follow basically the ACR paradigm to acquire the SPECT data. You do a CT, and you do your traditional iterative reconstruction with scatter correction, attenuation correction, and then you have a baseline of what your SPECT CT image quality looks like. And then on an annual basis, you repeat this, and then you kind of trend it, historically with time to see if the performance is changing or not. Okay, so those are the kind of the two things. Like I said, the important thing is really this registration test that we think is sort of an important thing to do. We have service events where the gantry of the SPECT and the CT is split apart, and so we actually verify these things every time gantry is split apart. So it's not only just for annual, but any time the integrity of a SPECT CT system is compromised, we recommend that this be evaluated. So I'm going to now switch gears again, and I'm going to look at a little bit of clinical imaging here, just to kind of give you a flavor of what is the clinical value of this. So I've just listed out a various number of radionuclides that is actually you can do SPECT CT on, and not all of these are investigational. Most of these are actually reimbursable here. So just SPECT has been around for a long time. So I'm going to show you some examples to kind of show you the value of this here. So just to start off with, at least in oncology, the bread and butter scan is a bone scan, right? So bone is a very common area of metastatic disease. So a lot of patients in our clinic are going to come with a bone scan here. So here's an example of 2 patients that have bone scans where you can see their L4 has got focal uptake. So the question becomes, is this metastatic disease, is this trauma, or is this inflammation, And so when you look at a planar image, that decision, is difficult. But when you start looking at this in a SPECT CT image, by looking to see what has happened to the CT of that area, you can see, this is just some degenerative joint disease here because there's high calcification of these bones. Whereas when you look at it in this patient here, you can see, well, parts of the bone are basically compromised. So this was basically dictated as being metastatic, while this was considered to be degenerative joint disease. So SPECT CT actually plays a big role in differential diagnosis. You will piece things apart that perhaps look similar in 2D imaging. Another area that we do a lot of SPECT CT on is something called parathyroid adenoma. So sort of women, when they hit middle age, they have hyperparathyroidism. So they have ectopic adenoma that is producing a lot of parathyroid hormone. So the idea is the treatment is to basically resect the adenoma. So in the past, the tradition of doing this was you administer actually the same thing, sestamibie, the same one you use the MBI and the cardiac, as you can see here, the myocardium is lit up here, and then you do planar imaging, and then you identify, here is the adenoma, and in the past, this was a exploratory surgery. You just go in there and you make 6 or 8 cut incision, then you go wander around, you try to find this node, and you cut it out. So you can see, and so it is an overnight hospital stay. It was a pretty major surgery. So that's planar. So if you do SPECT, you can actually say, okay, well, I can see much better a little bit. I can localize this sort of being stuff somewhere in the thorax. I have a much better delineation of sort of where in the thorax it is. I can say anterior, posterior, it's sort of up here. But I still, at least in my turn, I can't have a good sense of where it is. But now if I fuse CT with this, right, it becomes very clear for the surgeon exactly where the adenoma is located, and they can plan their surgical planning. So instead of going from a 6-inch type of incision, it now basically becomes an inch slice, okay, and it becomes a day procedure, okay. So the adenoma is resected, and the patient goes on the same day. So morbidity of the patient is actually decreased dramatically. So in our institution, at least, every patient that has a scan undergoes SPECT CT. This is very similar for like lymphoscintigraphy. When we do sentinel lymph nodes, when they go surgery here, it's the same concept. You do peritoneal injection of sulfur colloid, and you try to find the sentinel lymph node, and we do SPECT CT out here, and that is used for surgical guidance. So surgical guidance is actually a very important, is an area where SPECT CT has made some contributions to it. Sort of another area is yttrium-90 microsphere therapy. This is for management of liver diseases. So there is a couple of approved devices out there. But the role that sort of nuclear medicine SPECT CT plays is they use Tec-99m macroaggregated albumin as a surrogate for planning of these therapies. So we can see SPECT CT can visualize the tumors and the distribution within the liver, or even extrahepatic distribution very well. Papers have shown that when you use SPECT CT, your sensitivity and specificity for looking at extrahepatic uptake is very high. So that way you're going to be reducing your chances of complications or ulcerations by looking at SPECT CT. And after you do the therapy, you can also visualize to verify that adequate delivery with radiation was achieved, and there are techniques to sort of quantify what is the Y90 uptake and actually determine have you achieved the desired doses to these tumors. Some other areas that SPECT CT is being used for is in radiation oncology point of view, is to use functional imaging during their planning technique. Okay? So this is a study that was done at Anderson a number of years ago where they were using lung perfusion to adjust your external beam treatment plans. So in this case, you have a patient who's got a lesion on the right lung that needs to be treated, and the left lung is well perfused and very functional. So the goal is, can you create a plan that preserves the left lung, or maximizes, or reduces the dose that you're going to give to the left lung, yet treat the lesion in the right lung as effectively. So here are two anatomical plans, and you can see this is without using the information that the left lung is very viable. And then once the functional information is incorporated, you can see these margins have shrunk down considerably. Okay, so the idea is you can still achieve the same level of doses for this tumor, but you're sparing normal tissue that you know is working well, right, and yet achieve good therapeutic. And so here's an example. So that patient basically gets treated. You can see the right lung is very fibrotic here, but after treatment, the left lung is still very viable, and the patient is doing well. This similar approach is being explored for doing like HCC treatments at Anderson when they're doing sulfur colloid for the liver to assess what parts of the liver is actually viable here. And when they're planning IMRT for treating HCC, they're trying to prevent radiating these parts that actually have functional liver cells. So that's sort of another application of SPECT CT here. Another area that SPECT CT is used for is to do targeted radionuclide dosimetry, so patient-specific dosimetry here. So here's an example I'm going to show you where we're actually going to do a samarium EDTMP for bone metastatic disease here. So in this case, we do something what is called 2.5D dosimetry. We do whole body planar imaging, so it is 2D dosimetry of various time points, and then we do SPECT CT at a singular time point, okay? And we normalize all of the uptake to the SPECT CT scan, because in SPECT we've done all the corrections, but the profile is achieved from the 2D imaging because it's easier to actually do that. So the idea is, so we get the shape here from 2D, but the normalization, the absolute value here, is based on SPECT CT. Okay, and then we do our planning here, and we can actually determine our doses here. So for example, in this patient, we were able, in this trial, we had to keep the tumor doses to be greater than 40 gray. We want to keep the bladder and kidney less than 20 gray. And for this patient, we was able to achieve that, and we delivered this patient about almost 2 curies worth of samarium EDTMP, and really, the dose to that lesion on the humerus was 172 gray, okay, per our calculations. Okay. Yet, the dose to the bladder and kidneys was less than 20. So we were able to do very specific, patient-specific dosimetry. And so there are a lot of studies that are being done right now. This is just an example to kind of highlight the value of SPECT-CT sort of in clinical practice. And then some of these works are exploring as the ideas to do maybe whole body SPECT. So we looked at things like maybe instead of doing whole body planar, can we just do SPECT, quickly across the body and get whole body SPECT-CT scans? So these are still under investigation. We haven't quite, no. Another area is to sort of combine SPECT-CT with contrast CT. So here's an example, again, of the parathyroid adenoma that I was talking about. So here's the SPECT, here's the CT here, and I want to zoom in on here a little bit. So here's a non-contrast CT we normally get with SPECT-CT, and we see this is a hot spot here. Well, there's a lot of soft tissue. It's hard to tell exactly where this is. But when we add now contrast scan out here, you can identify the parathyroid adenoma from the carotids and the thyroid pretty well. So there are certain cases where actually, fusing SPECT-CT with a contrast CT makes sense because, you can actually use detection from information from 2 different scans and synthesize them together. So just to sort of summarize the clinical benefits of SPECT-CT is really, it improves visualization, diagnosis, and interpretation of disease, okay? It's got higher sensitivity and contrast and planar, okay? And this is very important, actually. CT scan increases the confidence in the interpretation of SPECT exam. So once our clinic started doing SPECT-CT, they didn't go back to SPECT. So we don't do SPECT anymore, So your institution is SPECT-CT, And I think that's what you find. A lot of places, when they get SPECT-CT, they do SPECT-CT. They don't go back to SPECT. I can give you examples of how there's a role in surgical planning, IMRT treatment planning, Y90 therapies, and some radionuclide therapy planning. Okay. There are some limitations. Like one of the things is the spatial motion between SPECT and CT scan. And unlike PET, SPECT, we have not really incorporated management of motion very well. So respiratory motion, cardiac motion is still issues in traditional bread and butter clinical SPECT-CT scans. Contrast CT has been explored, but there's still not a push-button solution like you have it in PET. In PET, it is a push-button solution to contrast correction. And although there is some work being done on quantification, this is still not mainstream yet. But I think both these areas, there is a lot of work being done. And I think in the next few years, we should see substantial progress in these areas. Good. OK, so so this is time to do some SAM questions here. I've given enough delay time, so hopefully you can actually stress your brain a little bit now. So which of the following is the most important function of the CT component of a hybrid SPECT-CT system? Is it for patient positioning in the SPECT scanner? Is it for scatter correction? Is it for generation of an mu map for SPECT attenuation correction? It enables a faster SPECT scan, or is it required for reconstruction of SPECT data? Please make the answers. Okay, well, very good. So the answer indeed is it is the generation of linear change coefficient map for SPECT attenuation correction. And I've given you a reference out here for that. The second question is, iterative reconstruction techniques like ordered subset expectation maximization are routinely used for reconstruction of SPECT emission data from hybrid SPECT-CT because they're not affected by scatter, they're not affected by attenuation correction, they require shorter computer processing time, they can actually model the physics of a gamma camera photon detection, or they require CT images for image registration. Okay? So, okay, so a large fraction did get the right one here. It is. This is a reconstruction toolkit, so it's, it basically what you put in, it is, I mean, if you don't want to inquire for scatter, and it doesn't incorporate scatter, the reconstruction toolkit incorporates these two things, but don't depend on them, okay? So the answer is they can really model the physics of gamma camera, and here are some references that talk about it. want to make sure the next slide comes on. Is it going to come on? Yeah. Okay. I don't know why. Okay. Good. So the most common transform from CT number to SPECT, linear attenuation coefficient, is what is it? Is it a simple linear line there where the mu attenuation coefficient is proportional to Hounsfield unit? Or is it again linear where the constant is based on the effective energy of the CT? Is it again just simply linear where the constant is proportional to the radionuclide photon energy? Or is mu just independent of everything? It's just a simple constant. Or is mu a bilinear function with a slope that breaks around water? Okay, so is it, how does mu vary? Is it linear with HU or is it a bilinear function with HU? Right, okay, good. I mean, I guess it was an easy question here, right? So most of them is going to be, it's a bilinear function. Remember, again, at the low end, it's dominated by photoelectric, right? And then as you go to higher Z's, which is basically higher HU, then the low energy is Compton scatter, sorry, and the high energy, the photoelectric kicks in. The new test for SPECT-CT is recommended by the TG177. The new test for SPECT-CT is which one? Is it SPECT image quality? Is it SPECT-CT spatial co-registration? Is it SPECT resolution or SPECT MHR COR? Okay, good. So SPECT MHR COR is needed actually to generate SPECT images. But really the new test that is unique because of CT is to make sure that images are co-registered. And although the report is not out, we are in draft preparation. It should be out soon. So the minimum CT dose appropriate for a SPECT-CT scan are constrained by which of the following? Is it the accuracy of CT-based attenuation correction, radiologist's preference for CT image quality, equalize the CT dose to the, sorry, should be SPECT dose here, and accuracy of SPECT scatter correction. So which of these drive the CT image quality? So it's good. Okay, so I want to point out that the accurate CT-based attenuation correction, you can really dial down your CT scanner to the lowest possible, okay? And it'll still give you good attenuation correction. SPECT accuracy is not compromised. Okay, so it is really driven by radiologist preference. Okay, so there is a reference here that talks about that one here. And so this is the last question here. The following steps improve the spatial resolution gamma camera images. Choosing a camera with a thicker crystal, using a coarser image matrix, image with the lowest gamma energy when multiple images are available, or position the patient as close to the collimator face. Okay, very good. So, yeah, already got it, right? So, it is positioning patient close collimator face. Dustin, I have a few more minutes, right? Yeah. Good. So, I have a few slides. I want to just make sure, just to show some of the new things available, since got to get your money's worth, right? Okay, good. I want to make sure I covered all the important stuff till I just covered some of the new things. So, there are some new things that's coming down the pipe. So, I just want to kind of show you the perspective looking forward here. So Siemens, and I'm going to give you some of the new things coming from Siemens, GE, and Philips, okay? There's no bias out here. So just kind of showing you what might be available should you go to SNMMI, all the RSNA and the floor shows out there. So Siemens has something called this Intivo system here. So the idea is they have been having a diagnostic CT scan, but clearly they actually produce quantitative SPECT images. So they'll actually give you becquerels per ml as an output, okay? And it has some very advanced SPECT-CT reconstruction I want to highlight next here. So traditionally, when you do, and these are clearly, you can see the slides from Siemens that I've just borrowed, okay? So traditionally, when you do SPECT and CT, CT is really used for attenuation correction, and then during the SPECT reconstruction, you just do SPECT reconstruction, you model attenuation, and that's it here. However, one of the new things they're looking at is, rather than looking at, doing the standard reconstruction, they're modifying that probability density matrix by the CT signal itself. So for example, they know that if you give MDP, MDP goes to bone, not going to go to soft tissue. So they look at the CT image, they kind of identify regions of the bone within the CT image and assign those voxels higher probability for the origin of MDP. Okay, so it sort of makes sense. So you're using more information, right? So rather than just randomly assigning equal probability, they're using information, where might the radiopharmaceutical go? So, and that's sort of what they're trying to illustrate out here, is they take the CT image, they segment it out to see spongiosal bone, soft tissue, cortical bone, fat, and then use this differentiation as part of the reconstruction here, okay? And so what does that image look like? So this is what the outcome is. So if you do FBP, here's sort of an example of the image. Here is what they have called Flash 3D. That is their SPECT reconstruction. And then here is a different method. I'm not going to talk right now. It's called conjugate gradient methodology. But then here is the method I just described here, where you're using the fact that CT is going to go to bone, so you can appreciate the changes in image quality, right? And so that's one of the things they're promoting. So so it looks to see if it's, our clinicians seems to like this, but it'll be interesting to see how the community responds to that, okay? So there clearly is a lot better visualization of the sharpness is increased dramatically. So that's one thing. So a couple of things about GE here. They actually have now their SPECT CT is called the 670 Pro, where they have a diagnostic CT scan mated with their SPECT system. And they also are able to generate quantitative SPECT images, okay? So one of the features they have in their system here is traditionally SPECT field of view is larger than the CT. CT is traditionally 50 centimeters. Well, SPECT could be 54, 60 centimeters. So there is cutoffs, there's regions of scan that you see in SPECT, but you don't see in CT. There's truncation issues out there. So one of the features of this scanner is that they can expand their CT reconstruction to much outside the traditional 50 cm view, although it is not necessarily diagnostic, but it is accurate for attenuation correction. Okay, so they have this feature where they can extend things out here for attenuation correction. The other thing they have is their SPECT CT is a more modern CT, and they have sort of a lot of their bells and whistles of their diagnostic CT scanners coming into their SPECT CT system. So for example, they have Acer, and they have some very high-pitched CT options available with these systems, okay? And this is like their promotional stuff, so I'm just kind of highlighting some of the things. And so they also have something called a Q suite. They have a whole pathway to get quantitative imaging, and you can see here, they do dead time correction, they do sensitivity correction, they calibrate their system with an isotope, and when they apply reconstruction, sort of those system sensitivity is incorporated to actually get together with the administered activity to figure out what the quantitative values are. And then they also provide something, a dosimetry toolkit that you can incorporate their SPECT images and their planar images, draw regions of interest, and get time activity curves for radionuclide therapy planning. Okay. It's not necessarily new here, but Philips, their kind of the top of the line SPECT CT system is this Brightview XCT, and here their CT approach is very different. They don't use a diagnostic CT scanner, but they use a flat panel CT system, okay? And here's the flat panel here, and here's the X-ray tube source. And it takes 2 iterations to go around to collect, because you can see the flat panel's offset, okay? There's not really, and these are not, like I said, they're not diagnostic, so they're slow rotation, okay? But the value is that the images that you get here, so here is your conventional CT, okay, here's a foot scan they're talking about, right? And then here is the CT that you get from SPECT CT, and they're showing here SPECT shows some uptake in this region here, and when you look at this region, you're finding a bone spur that you can identify in the CT, where in the diagnostic CT, that may be more challenging. So there are some certain applications. Clearly here, one of the challenges is that because these are slower scans, right, the requirement that anatomy be stationary is an implicit here. So something like abdominal or thorax scanning may be challenging, okay? And they have also done work with, improving their reconstruction, SPECT reconstruction toolkit, where, they are able to enhance image quality with, for example, 15 seconds a step. So they not only have they reduced their scan time, but image quality is also making. So they are also making advances sort of in their reconstruction toolkit as well. So I sort of want to, always have to take home message, right, at the end of the talk here, right? So the take home is, nuclear medicine, right? Always been, what have we bumped around? Unclear medicine, unclear medicine. I'm sure John has said that sometime in his lecture. Unclear stuff, right? Yeah. So, but that's passé, okay? It's time to move on, okay? So SPECT CT and SPECT CT really changes to nuclear imaging, okay? So it is still nuclear imaging, all right? So I want to thank you for your attention. I'll take any questions you may have.